Welcome everyone to today's program. I am Kathy Brett with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And our presenters will attempt to answer as many questions as we can during the time we have and follow up on any questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program, and you can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to turn the floor over to Bryan Warren, Manager of Healthcare Solutions at Select International, who will introduce today's presenters.
Thank you, Kathy. I have the pleasure today of moderating a discussion with two outstanding speakers. Dr. Todd Hold is the President of Georgia Emergency Services. He's a practicing emergency room physician, and his company provides emergency department staff to hospitals. In this role, he's had the opportunity to work on process improvement and patient experience initiatives in a number of hospitals. We've been working with Dr. Hold on issues related to physician performance over the past few years, and we wanted to include him in today's discussions for two reasons. First, he wrote a guest blog for us last year about the outstanding success at Gordon Hospital with regard to their patient satisfaction scores, and we wanted to share that story. But more importantly, we wanted to tell that story from the point of view of a physician, and in this case, a physician who is not a hospital employee, but responsible for the performance of a portion of the staff in the emergency department and some of the complications created by that relationship. And we realize this is a fairly common situation, but we think that Dr. Hold's approach and the level of collaboration he has with hospital administration may not be as common as we'd like it to be. I think you'll see it's a very practical approach, grounded in doing what's right for the patient, and he also emphasizes that many of the process improvements that we look at with patient satisfaction, particularly in the emergency department, may not be complicated, but they depend to a large degree on the behavioral skills of his physicians and staff, and he's particularly attuned to that. We also have with us Paul Glatzhofer, who's a consulting manager for Select International. I have the pleasure of working with Paul as he guides his hospital clients towards building a high-performance culture. We like to say that patient satisfaction success comes from a combination of process, technology, and culture. And Paul's particular area of expertise is defining the specific behaviors that drive culture and then teaching hospitals how to build teams that consistently display those behaviors. You can change the slide, Kathy, and we'll talk about the agenda quickly. We want to talk for just a moment about the role of behaviors and culture on outcomes. Then we'll get into the unique challenges of improving the patient experience in the emergency department and get on to the primary agenda point, which is having Dr. Hold tell us what he's learned. And then Paul's going to tell us about the talent strategies that support what Dr. Hold is trying to accomplish. And as Kathy said, we'll save plenty of time for questions. If it looks like there's a question during the presentation that's particularly timely, we'll... Next slide. Thanks, Kathy. With the implementation of the HCAHPS program, every organization is obviously committing resources to improving the patient experience. And most of these resources have been committed to better survey data, how that data is used to drive process improvements. But more recently, we're realizing that outcomes, both patient satisfaction and clinical outcomes, are driven to a large degree by individual behaviors and organizational culture. For instance, in 2004, the healthcare industry set out to eliminate wrong site surgeries. We, Joint Commission, issued a set of universal protocols, checklists, marking the site, those sorts of things. But almost 10 years later, we still see nearly 3,000 wrong site surgeries each year. And you can see, and I found an interesting quote from the New York Health Commissioner who was looking at this problem. And it recognizes that there is a very strong behavioral component to this, that there is an issue of conscientiousness, attention to detail, collaboration, and a culture of accountability, even when the process is something as simple as marking the site of surgery. Next slide. You can see the same thing with ICU central line infections. Everyone's probably aware that several years ago, several hospitals published studies, research where they were able to essentially eliminate central line infections by implementing certain processes and procedures. And I think everyone was optimistic that once most hospitals adopted those processes and procedures, we would see a significant decline in central line infections. But yet we still see over 40,000 each year. And I thought the quote from Dr. Stanza was important. For the process to work, each individual has to make a commitment to perform each step each time. And what you see, again, it's a cultural issue. We need a culture that values and reinforces the commitment to perform each step each time, and where colleagues hold colleagues accountable. And I think these are great examples of where behaviors play a very important role in addition to process and technology. Next slide. And now we can talk a little bit about behaviors as they impact patient satisfaction and the patient experience. We had a funny story recently. We had a hospital CEO that we were working with for a small system in upstate New York, and he told us that he had implemented several different patient satisfaction programs and actually had scored rather well in the implementation of these programs. In other words, they had done a wonderful job implementing all the steps, be they rounding, scripting, facility changes, process changes, but their patient satisfaction scores were still stagnant. He said one morning, though, walking into his hospital, he saw a bumper sticker on a nurse's car that said a nurse's job is to save your behind, for lack of a better term, not to kiss it. And he realized that he had a cultural issue. In his organization, nursing did not see patient satisfaction as a priority. And so the next program that we put in place was really focused on culture and behaviors. And you can imagine, think about your own situation as you implement patient satisfaction initiatives or programs, and the role of empathy or communication, collaboration, and even adaptability to new programs and new approaches. You can change the slide, Kathy, and we can move on and talk about the emergency department specifically now. So the emergency department presents a unique set of challenges with regard to patient satisfaction. First, we have to recognize, I think, that patient satisfaction scores are not the ultimate goal. Some would say that the score is just a measure of the patient experience, but even that's really not sufficient. We've seen that physicians and staff sometimes, for instance, balk at these efforts because they're presented sometimes in isolation as the most important performance metric, and I think we lose something in the message when we let that happen. When in reality, patient satisfaction is part of a complicated set of metrics, including clinical outcomes, staff satisfaction, retention, turnover, and of course cost of care. And in the emergency department, there are complicating variables that impact the patient experience. We have to talk about wait times and pain management, communication, empathy, and attitude, and the issue that Dr. Hold can speak of, that some of the staff may not even be employed by the hospital. So it's a complicated problem within the emergency department. Next slide, Kathy. And obviously, CMS and other payers have embraced the concept of value-based purchasing and identified patient satisfaction of a key marker of value. And you note here we say for better or worse, primarily because I think we need to recognize that some providers still raise questions. Some of these are valid, about how we measure patient satisfaction and its role and how we make decisions and measure the quality of care. HCAHPS and related programs, though in reality show that there is a correlation between patient satisfaction in the emergency department and your inpatient HCAHPS score. So emergency department patient satisfaction scores are important. And hospitals expect their emergency department and their ED physicians and staff to take patient satisfaction very seriously. So while we can acknowledge to skeptics that value, which might be a perception, may not be the same thing as quality, i.e. a more objective measure of outcomes and evidence-based standards, we're starting to see there is a real correlation between patient satisfaction and, for instance, lower admission rates, and between empathy and improved management of chronic disease. Next slide. And Dr. Hold, before we get into your background in the story at Gordon, I found it interesting, some recent research, that one of the additional challenges is the unique relationship of the emergency room physician to a patient, which is different than some other folks. Do you want to comment on that before you get into the Gordon story?
Yeah, sure, absolutely. I guess us, like nobody else except perhaps the urgent care setting, which even they have more of a recurring kind of patient pool. We have very limited time to sort of establish a relationship or rapport with patients. So I think that factor alone really changes the game, because if you're in the office setting, you have multiple chances. I always said first impression is you only get one shot, but truly in the ER, that's extremely the case.
Tell us a little bit then, just on a high level, about the story at Gordon. Gordon had some unique challenges with patient satisfaction in the emergency department, and you've had some outstanding results.
Yes, we are very fortunate at Gordon. I'll back up and say, first of all, I really appreciate being on this, and then the other thing, I just want to recognize some key folks in my experience, and that's the many leaders and administrators I've had the privilege to work with. Any success is, I have to credit them for that. But at Gordon, we are very fortunate. We had I'd say we were kind of the typical ER situation in that we took the contract over probably in the mid-2005, 2006 era. At that time, we were seeing about 17,000 to 18,000 visits per year, and we're in an old department. What I mean by that is, there wasn't a lot of patient privacy, and it just wasn't set up good for flow. So kind of those things you mentioned that contribute to patient satisfaction or good scores were lacking. Around, about 2 or 3 years ago, they built us a new ER, or they broke ground on a new ER. And prior to that, we had kind of done the typical experience of having meetings saying, hey, we care about customer service. Let's make this a priority. We might develop a process team that met for a couple months, and of course, the end result was mediocre results at best. Well, upon breaking around this new ER and building it, there was finally a true commitment from administration to really follow through with it. So at that point, we bought in and really committed to this customer service initiative. Initially, at that point, we were running probably the bottom 15 to 20% was our typical score. And I would say about 2 or 3 years ago, when we got really committed, we, in 2 to 3 quarters, moved into the 99th percentile and have basically stayed in that upper quartile since. So we're really appreciative of.
Just to reiterate, Dr. Hold, you provide staff, yourself, and other physicians and providers to Gordon, correct? And other hospitals.
That's right. We are independent contractors. We're a group that basically we bring in mid-levels and physicians only. That's all we are responsible for as far as staffing goes.
Okay. Kathy, you can change the slide quickly. I wanted to have Dr. Gordon speak for a minute about some of the skepticism you run into, and when you run into that, some of the rationale you give for why patient satisfaction scores are important. I thought that was an important message in the story that you told us.
Yeah, this next slide I love. I think this is probably the crux of, well, this is the biggest battle we have really, or at least in my position is, I can easily determine who is a good clinical provider, but when it comes to the softer side of medicine, that's the real challenge. I think that's where a lot of people struggle. But this slide does a very nice job of summarizing. It's kind of the key points that I take to my providers when we are kicking off an initiative. Now, you did a great job of mentioning that there's a lot of pushback on this often, a lot of skepticism. So I'd like to, here shortly, we'll go through in greater detail how I address this with my providers.
Kathy, next slide. And Dr. Hold, we'll get into the more detail, but I think that when we talked about this, I found it striking that you really had three primary points that you felt were most important. They had to do with that reaction. They had to do with discouragement and making incremental changes. Can you speak to that?
Yeah, so naturally, as an ER physician, until you've done this, you can't imagine the pressure that can hit you in the emergency department, from unpredictable volumes to high acuity to frustrated families, patients. Customer service, in my experience, when I go to my folks and we talk about this, they're kind of like, man, I've already got volumes. I got high volume showing up. I got high acuity stress. I'm managing mid-levels. Got angry patients, wait times. And then there's the whole documentation world that's changing quickly on physicians. And I think most of the audience is aware of this, is that there's a real push to go to the EMR. Well, that's a major stressor in the emergency department. So obviously, when I go in to discuss customer service with my folks, they're like, I run into some real pushback on this. And that's kind of the first bullet there. So naturally, that's one of their major pushbacks. And then the second big piece here is that often we're going in to these providers and we're going, hey, we're at 15th percentile, 10th percentile. The hospital wants us to get up to, they want us in the upper quartile. Or a lot of times you've got an administrator going, hey, we've got to be in the 90th percentile because reimbursement is dependent on this, and it's just kind of the typical goal. So the important thing to understand about these percentiles is that it isn't a great big difference between, typically there's not a great big difference between being in the maybe the second to the bottom or mid quartile. We're talking about when you look at raw scores, it can be incremental. So that's what I tell my providers, is that, yeah, we're making a big jump here, but it from the raw score standpoint is not significant. In other words, minimal changes can move us ahead of the competition. Does that make sense?
Yeah, and I think it points out that rather than just taking the message to staff to improve, that there's some education about the tool, about what the data means, and what it's going to take to get there. And I think that's exactly. Probably what, from a story you told me, that is something that allowed them to get over some of that initial discouragement of how do we move from 15 to 90.
Well, Brian, I'll give you an example. Is that just at Gordon, for example, and I think I mentioned this the other day, the difference between 15th and 99th or 90th at being ethical, you can't tell the difference really. It's not like I walked in, and I mentioned this the other day. It's not like we went from cloudy, bleak days to sunny, colorful flowers and birds singing. It's minimal. It's very attainable. And during my time even with some of the other bigger companies that I served with, we went to their kind of model ERs that were consistently pulling off the 90th percentile or greater. I couldn't tell much of a difference. When you go in, they still, it kind of feels the same, but it's the little kind of details of the habits that we form that make the difference. And we'll talk about that a little bit.
Kathy, next slide. I want to get into, Dr. Hold, some of the, when you wrote the guest blog for us, you hit a couple key areas, and I'll just list them, and then we can talk about them in greater detail. But the first thing you said was make the patient experience a provider priority, make it a hospital priority, somehow create accountability, to appreciate the limitations of training. I thought that was interesting, to lead by example, and the concept of balancing persistence with patience, and then ultimately, or at the end, at least at some point in time, you have to think about building the right team. Let's take a few minutes and let you give us more detail on each. Kathy, if you could change the slide, and we're talking about making it a priority. So go ahead and start with that concept that training has its limitations, but it's part of the idea of making the patient experience a priority.
Yeah, well, I like to use sports analogies, and I apologize for those who are into this, but training, that's a great topic to talk about. Let's use a baseball analogy. We'll just take a left fielder in the major leagues. Well, you know, he's not only does he's got to have the right tools, such as a great baseball glove, some cleats to run with, maybe even a hat to shade the sun. That's what I consider training. I think it's a key part of the process of getting your providers to deliver this customer service we're pushing for. And for example, you know, that might be the 8-ish mnemonic. I'm sure everybody's heard of that. Or perhaps it's, you know, the numerous process teams, the processes we change in the ER to impact throughput, pain control, those things you mentioned. So that training role is critical, and I think most facilities do a great job of addressing that, because you can get your head around it. It's something tangible you can sort of implement and put some time into. But I think, and actually this slide, there's two key points I think today that I'd like to make, and that is when it comes to failures, and I don't want to use failures, that's a little strong, but folks that have really tried to implement customer service and had substandard results, there's two key areas that this occurs in. The first is just paying attention to the human psychology side of their people, and the second is flat-out selection. And what I mean by that is who you hire, who you keep, who you invest in, and who you eliminate. On the human psychology side, I think this is a major challenge for leadership. It's very difficult, and this is such a key part of success, the habitual long-term success we're looking for. And the way I kind of approach my people is I kind of have a three-pronged approach, and I think this will make sense here. And again, this isn't any kind of standard training I receive. It's just the way what I do in my real-life practice to improve the folks that work for me. I kind of look at it from three-pronged approach. The first is environmental. The second is the competencies that these providers possess. And the third is motivational. So again, this is no kind of standard. It's just the way I approach my individual providers when I'm trying to coach them up, so to speak. So the first one I'd like to talk about is the environmental. This is a sort of a key piece. I've got folks who, you know, like Dr. A, he might deliver great customer service when he does 12 to 13 shifts a month. But if I put him on 15 to 16 shifts, I start to see a different animal. I mean, I start getting patient complaints and lower scores. And by the way, let me back up and say this. For those listening, if you have the ability in your reports, now I don't know how many people utilize customer service reports, but if the availability is there to drill down on the individual level, that's critical. I'm so thankful because at Gordon, they have spent the resources to get us individual data, not just individual scores, but I can go back, like Dr. A, I can go and see what his scores are on day shifts or night shifts or weekend shifts, etc., maybe holiday shifts and so forth. So that's an important piece to this. Additionally, maybe the number of shifts. You know, you gotta. I kind of always am watching these things. If I see that a provider had very bad scores in the month of November, I might go back and look and say, how many night shifts do they have? How many shifts overall? Things such as that. Additionally, who are they working with? What staff is there? Maybe they have a staff issue. Those are the types of things that, on that first piece, the environmental piece, that, and I'm very fortunate that I am able to take the time and really dig into this, because I can isolate some of the sort of trouble points, so to speak. And of course, we're always looking at who our kind of lower scoring providers are. So obviously, if you have a great provider, you're not really spending much time on them. The second piece on that three-pronged approach is the competency, the ability and beliefs of these people to provide customer service. And Bryan, this is where I really struggle, because I just don't have the tools to really look inside the person. And up to this point, it's been kind of trial and error. You know, I kind of speculate, and I have a good education, a lot of experience. But as far as evaluating the competencies, it's been a challenge. And what I mean by that is just the ability, the beliefs that people have. You know, some folks believe that treating others right is important. Some don't. And so, and additionally, maybe even if they do believe that's important, they really don't know how to. Maybe they've just never been shown how to, or they just don't quite get that. So certainly run into that as well. And then
it actually sounds like the processes are fairly simple, but the biggest challenge is really buy-in and behavioral. Is that what you found with your staff and even with the hospital staff?
Oh, always, yeah, buy-in and behavioral, yeah. And then the last thing related to motivation on that three prongs, the motivational side. You know, some are motivated by money, some by recognition. These are all the pieces I try to put together. And again, I'm always looking at kind of my challenging people, the folks that are kind of pulling us down. And again, if you don't have that data, you can't even start here. You can't do that sort of thing. But yeah, that's a good summary. And sorry,
you had also mentioned when we were talking about, and I'll wrap us up on that slide and move us on, but you talked a little bit about the hospital expecting you to hold your people accountable, but then you needed to communicate with the hospital that they had to create a culture of accountability for their staff as well. Can you speak to that and how you handled it?
Absolutely. I mean, it's a concerted effort, and anybody that's ever tried this knows that if there is not a complete commitment from leadership down to the frontline employees, in other words, the folks that actually touch and see and interact with the patients, and I mean from housekeeping all the way up to administration, one piece is missing, and an experience can go bad. And, you know, it's like, well, I'll tell you what, a little bit later I'll get into it. Maybe we'll have a chance to talk about our experience at Gordon. We have had a couple soft quarters from the customer service standpoint, and have been able to drill down and realize that just two hires in the last 6 months, we think are the cause for us dropping out of the upper quartile. The last 2 quarters we've been like 70%, I think, 60, 70%. So again, cannot emphasize enough how critical each person is being involved in this initiative and sticking to it.
Kathy, you can change the slide for me. And then on this next slide, we were talking a little bit about accountability. Leading by example, I think, is pretty obvious in that you spend a good bit of time in the emergency department yourself, and we know that you have a particular patient satisfaction focus. But you also mentioned in the blog that you wrote the balancing of persistence with patience. What were you speaking about there?
Yeah, I think that one of the things you can't do, one of the mistakes you can't make is go in and beat up a provider with scores and stats and even criticism. I think I've seen that fail so many times. And I think that it's constant patient pressure, I think the term I use, is that, we keep bringing this up over and over and over. And one of the things I do, obviously when I'm working, I still work shifts, I still go out, still see patients, and I follow our training to a T, of course. I have to, and I actually want to, and it works. There's no doubt it works. And AIDED is everybody familiar with AIDED? Should I go into that? You might want to
define that, Dr. Hold. I'm not sure everybody is.
Okay. AIDED is sort of the mnemonic that has gained pretty good momentum in the customer service world, and it stands for, it's kind of the path we follow when we see a patient. So it's AIDET. A stands for acknowledge. You just walk in, warmly address the patient, any family that's there. Reach out, touch them, shake their hands, tell them who you are. That's introduction. That's the I. D is duration. And one of the things, it's always about managing expectations. Tell them how long things are going to take. Huge difference between, tell them what you're going to do and walking out of the room versus tell them what you're doing and say, hey, this is going to take a couple hours. Big difference. And then the E is an explanation of results. It's amazing how often that this is forgotten by providers. They don't take the time. They don't remember that patients know nothing. And it's that daily, it's every encounter. You got to remember these folks don't know anything. And they want to understand their results. They want an explanation. And then the last thing is thanking them for coming. And that's really awkward in the ER because, unfortunately, in most cases, from the provider standpoint, you're hoping for less patients on your shift, And that's one of those things. As more patients come, it's great for business, great for the hospital, great for the bottom line. But when you're the one working that shift, most providers are paid by the hour. You don't want to see high volumes. So getting people to thank the patients for coming, that's been quite a challenge. But that's what AIDED is in summary. And I think, I always demonstrate that when I go in and try to get my staff to do it as well. I don't know what the impact of that is. I know if I didn't do it, it would be pretty negative. I would have very little ground to stand on to ask them to do it, obviously.
Dr. Hold, I'm going to move us forward a little bit just for the sake of time, but I did want to point out that I know when you were talking about your team, I know you told me that you actually had to make some very difficult decisions and decide that certain people just didn't fit where you were going to go, where Gordon was going to go. Even with staffing shortages, you actually removed some people from the organization, correct?
Yeah. Yeah, this is the other. I mentioned there's two key points that I think when facilities or hospitals really commit to this initiative, they make two big errors. The first is ignoring the human psychology portion, which I probably talked about too long. The second piece is this. I think this is the most common failure, is that obviously, there's a shortage of providers. It's a real challenge to keep our schedules staffed and keep enough physicians around. But I cannot emphasize enough that do whatever it takes to get rid of your kind of the folks that just aren't going to be sort of coachable. And the only way these folks are going to help you is if you move them to the competition. That's it. They're always going to be poison. And surprisingly, I have been surprised how it's kind of hard to identify these folks sometimes, especially as a leader. When I go in, I get a totally different behavior set than perhaps they would be if I wasn't there. Of course, that's what nurses are for. They'll always be happy to tell you what's going on when you're not there, and other staff. So, but pay attention to what your ancillary staff tells you, because I can think of a particular case of a physician who seemed to be the dream physician. When I was there, he was over the top. Just everything was great. And then I would constantly be hearing reports, when I'm not there, of things that he was doing and so forth. And it was demonstrated eventually in patient complaints. So I can't emphasize enough that there is a time that you kind of let go of these folks and move them on out. And additionally, the biggest challenge still I face is not hiring these folks in the first place. That's a critical piece, because once the black eye occurs, and again, we have to make mention that I am a guest at the hospital. I mean, there's other ER groups who want to have the contract we have, and they want the business we have. So when you bring in a bad hire, it's a black eye and it's a strike, and you have to remember that. So any way you can possibly avoid that is well a good decision for sure.
Well, that's a great transition, because Kathy, I'm going to actually ask you to move ahead to the slide that says Healthcare's Approach to Talent, and we're going to hand things over to Paul here for a moment. And really, Paul, a couple things I think are important out of what Dr. Hold is telling us. One is just that overall approach, and then common mistakes that you've seen. I think those would be useful for the audience.
Yeah. Thank you, Brian, and thanks everyone for having me today. So, as Brian points out, I really wanted to focus on healthcare's approach to managing talent, in particular selecting talent, and also discuss really how a really robust talent selection process can lead to great outcomes and get away from some of these things, these issues like Dr. Hold and Brian have been talking about. So one thing I think that was interesting, as Brian had mentioned earlier, which is kind of a good segue into what I'm going to talk through, is his intro on wrong site surgeries, and the thought that if we have a process in place, that process would eliminate these wrong site surgeries throughout the U.S. and the world. And really, what is the difference when we implement these processes across hospitals? The differences are the people that are implementing them and using them. And so what we really want to focus on is how to get the right people in the hospital, in the emergency department, so that we eliminate some of these issues and certainly raise those patient satisfaction scores. So a few things I want to talk through here just around healthcare's approach to talent in terms of where has healthcare historically focused their efforts in hiring? What are the data points they're looking through in the hiring process to try to determine if somebody will be a good hire? And whenever, Brian and myself and Dr. Hold, I'm sure, as he goes into his clients' hospitals, we talk about the selection process and we say, what are the things you're looking for? And it always comes back to those tried and true methods of you look at the clinical skills, the technical skills as we call them, and even more they look at, educational history. We know that people who went to XYZ University, and if they have the technical, clinical skills, they're going to be successful. Those were the data points that we could gather easily in a selection process and we could use to make a decision. And so as we have evolved in terms of the psychology of the selection process, we have some pretty tried and true tools, assessment tools, behavioral interviewing techniques that we can use to take this to the next level. So we don't have to solely focus on the clinical skills, although those are important. we want to look also at these behavioral competencies, as we call them, to make sure that the applicants who will become your providers have those right skill sets to take us into the next generation. So, and with that, we talk about the changing expectations or demands of these folks. So another, I think, story that Bryan brought up, which I think is relevant here, is that age-old thought process that nursing and physicians, their job is to really help us through the sickness, but they don't really have to make us feel nice as we are engaging with them and as we're working our way through the healthcare system. And those expectations are changing to where we really do have to focus, of course, on that patient satisfaction. We have to work together with the other departments, have that collaboration and teamwork. And as things are so confusing sometimes in the hospital environment, we need people who have good cognitive skills and good decision making. And so then it all comes back to how do we measure these things prior to bringing them, these candidates, into the hospital and into the organization so that we make sure we have a good hire. And if we can go ahead and move on to the next slide, we really think that there's 3 keys to building the right team. And the first one, of course, is the interview. I mean, everyone that's listening knows that, the interview is certainly a huge portion of the selection process. And there are some, when I go into hospitals and I talk to folks about their processes on the selection side, I feel like this is always the lowest hanging fruit is the interview, because a lot of times they're inconsistent interviewing processes, they don't have standard questions, and probably the most frequent is they don't have good consistent scoring. How do you actually evaluate the responses you get to an interview? That's the easiest thing, I think, to really help and fix in the selection process. And then kind of coupled with that interview is good behavior-based interviewer training. Handing a good interview guide to a hiring manager is only as good as that person using it and asking good questions. So that's the first piece. The second piece is screening tools, which sounds a little vague, but this is what I was speaking to earlier in terms of we now have sophisticated assessments that allow us to really dive into the personality, the knowledge, skills, and abilities of the candidates to get a good sense for, is this person going to fit in to the hospital, or should we move on and look at other candidates? And then thirdly, I think any good selection process that's doing a robust job of screening their applicants will have some developmental tools that they will know when a person gets hired, they still have some weaknesses, and we've assessed those throughout the hiring process, and we're going to immediately look at those potential weaknesses and develop them over time. And so that, in terms of our 3 key steps, those are what we want to speak through.
And Paul, we may not have time to get into it today, but I know Dr. Hold has started to implement, and we have other clients who started to implement new approaches to the physician interview, so that some of those collaborative behaviors, empathy, that ability to work as a team, that ability to be adaptable can be identified just like we would in anybody else, and particularly in an executive, that we're working on that with physicians as well.
That's right. Great point, Bryan. Okay.
Next slide, Kathy.
Thank you.
Because I think it's important to get into common mistakes. We certainly can show you some tools, and we had some very good questions already about what tools we could use to improve some of these areas, but I think it's important to talk about common mistakes.
Yeah, so just to work through these quickly, and then maybe we'll transition into some of the questions that we've gotten throughout the webinar. So some common mistakes that we've seen through our work with healthcare hospitals and healthcare systems. The first one, just pressure to fill positions. This is one we come up against all the time. It's that issue where you have an opening. Maybe it's a night shift, a third shift nurse, and you really just need a warm body in that role. And one of the things that potentially is driving this pressure to fill positions is a lot of times hospitals and systems are looking, especially in HR, they're looking at the metrics around time to fill. And while I don't think time to fill is a bad metric to review, it's something to consider, because that time to fill and the urgency to get a butt in the seat, so to speak, is not always the best approach. As I think Dr. Hold was mentioning, they drilled down in their patient satisfaction surveys to see that only 2 potentially poor hires were dragging and making them look at their patient satisfaction scores to drop out of that upper quartile. So obviously the selection is important, and every selection is important. The first shift nurse, the third shift nurse, and everyone in between, which leads me into the second point, which is devaluing the frontline staff. So it's kind of interesting that we hear this more often than not, in that the folks that are on the front line, so I'm thinking of folks like transporters and food service workers, folks that are, tend to be the lower paying jobs that we don't value as highly either in the selection process or even when they're on board, are impacting patient satisfaction, and they're impacting it in an important way. I can think of from my own personal experience, my wife leaving the hospital, and the last thing we remember is the positive interaction, I should say, with the transporter. And to this day, that's the most memorable piece of that interaction with the entire hospital. So it's certainly an important piece, and we don't want to devalue them. The third point here, lack of understanding of the required behavioral competencies. It's kind of a mouthful, but really what we're talking about there is that any good selection process, training process, is all based off of this idea that we know what are the competencies needed for successful performance. That's really the critical core piece of the project. Understand those competencies first, and then implement the selection procedures that map on and measure those competencies as the second piece.
So, Paul, in that case, in Dr. Hold's situation, you'd be trying to identify the specific behaviors that predict success, in this case, patient satisfaction scores, not only in an emergency department, but in this case, in Gordon Hospital or whatever hospital Dr. Hold's working in.
That's right. That's right. Yeah, the idea would be to look at all levels of the organization of the hospital to understand, what are the competencies needed, what are those competencies, and what are the differences across levels, especially when you get up to the mid-levels and physicians, and then devising your selection strategy based on the findings of that competency model. And then the last point, the horizontal and vertical counterproductive behaviors. This is kind of an interesting thing. I just wrote a book chapter, and I included this information in it. And really what this is speaking to, not necessarily a common mistake, but more about a negative environment. And it's, when we bring a candidate into the hospital, and they don't have the requisite behavioral competencies, they don't have that ability to work with others, is a huge issue. It can drive turnover of other employees, both peers and folks from other departments. So this is, again, kind of going back to that transporter example. We actually had a healthcare system give us the example where a high-level HR executive actually came to work one day dressed in the garb of the transporter, and she noticed that no one was looking at her making eye contact with her because they could see her coming, they could see it was clearly a transporter, and they weren't making eye contact. And this is that idea that everyone in the hospital needs to be working across departments, across levels, so that those folks feel like they're an integral part of the team, because we know that they are, and we know that they have a huge impact on patient satisfaction.
Hey, Kathy, can you move to the slide that says competencies across levels? Because Paul was speaking about identifying competencies, and I thought it would be important for people to see an organization. So, Paul, this is an example of one organization's high-level competencies across the whole organization, and then you would build a selection system and developmental program off of these competencies?
Yeah, that's right, Brian. So as everyone can see here, this is actually an entire hospital system where we look at and we bucket positions into levels or buckets. And so you see here we have 5 levels from support and services up through executive, and we've identified the key behavioral competencies at each level. So as I'm talking, hopefully, some of you may have been thinking, wow, this is a lot of work to go into each job and find out what are the knowledge, skills, and abilities, and it doesn't have to be that complex. Really, this one-pager that you're seeing here is encapsulating all of the behavioral competencies across all positions in a particular healthcare system. And to Brian's point, we did the research with this system to understand what are specifically the knowledge, skills, and abilities you need to be successful at the different levels, and then we devised all of our talent strategies around that.
And then, Paul, you talked about a few things. I want to get to some questions that we have. So, Kathy, if you could jump to the slide that shows the Nurse Fit tool, because Paul spoke about screening tools. I think everybody understands the concept about interviewing, but maybe we could show what one of these screening tools could look like, and it's a screening tool that's been shown to be predictive of certain competencies. Just a bit further. There you go, yep. Kathy, thanks.
There you go. Yeah, and so this is basically a sample output report from one of the behavior-based competency assessments that we use, particularly in the nursing area. And you can see here, we're measuring some of those key competencies that you had seen in that previous competency model. So we're looking at things like teamwork, collaboration, their decision-making processes, and their patient focus. And so the idea is, and kind of to tie back in with what Dr. Hold was saying, when you look at what's driving patient satisfaction, there's very few steps, easy steps, sitting with the patient, greeting them appropriately, saying thank you, things like that. Those are all very easy, but what the differentiator is people who are adaptable enough and willing to actually take that training and take those simple points and actually put that into action with regard to every patient interaction that they have. So this type of output report is extremely helpful for hiring managers to get a quick, easy sense for, does this person fit our environment, and should we progress and ask some follow-up probing questions in an interview, or potentially they're a poor fit and we actually don't want to progress them at that point and we want to save our valuable time for candidates who have a higher likelihood of succeeding in the role.
Thanks, Paul. We're a little short on time, and we have some very good questions from the attendees, so I wanted to hit those. The first one, hey, Dr. Hold, there's a question about how common it is to have something in your contract with a hospital specific to patient satisfaction. I know that you've told us several stories of working on these initiatives with your client hospitals, but the question is, how often is that somehow integrated into your contract, either the expectations or even bonuses tied to patient satisfaction scores themselves?
Great question. Surprisingly, and I think this is going to change, I think we're going to see a movement towards this more, especially as HCAHPS reimbursement begin to affect hospitals. But thus far, only one has really held our feet to the fire with this initiative. The other several, no. It's been a across-the-table spoken agreement that, this is really important to us, and I'm from the hospital from the administrative standpoint. And, we're very conscientious and care about this very much. So I don't think we've disappointed anybody, but only one. But as I say, I think that more and more, as the bottom line gets impacted for hospitals, this is going to be a definitely contractual, you're going to see this in the contract.
The other question we had for you, you had mentioned looking at individual level data. Do you actually use that data in a structured peer review process? Does everyone see their own scores? How are they used?
Oh, great question. I meant to actually discuss this and forgot it as I was going through my presentation. Yes, again, I thank the administration at Gordon for spending the extra money to get this very detailed data. But what I do with it is I post it in the lounge. I mean, in our physician and mid-level lounge, so all the docs, all the VAs and nurse practitioners see this. I even post the comments. We've gotten to the point where we have specific patient comments about our provider, and it's a fortunate group because this is a competitive group who doesn't want to be. They don't want to look bad. They don't want to be at the bottom. So that really works in my favor. Makes it much easier for me to succeed. And so that's been. And one last thing. I'm sorry. I know we're in a rush here. One of the other key things, and I highly recommend this to anybody that's listening, if you're not doing it, is to create a complaint accountability. And I got this idea from our administration. Complaints come in from patients frequently. 1 or 2 a week. And in the past, the tradition has been for the director to manage them and kind of sweep them under the rug and, call the patient, appease them. Well, at Gordon, we have a formal process where every complaint goes right up to the CEO and all the administrators and all the nursing, all the directors, all the departments, all the directors, all the departments. And what I do is I took it a step further. I include the provider on that complaint. I let them see everything, and then I let them give me a summary of what from their perspective, what happened in the visit and how we might prevent this in the future. So very effective. It's amazing how there's such an overlap between avoiding those complaints and at the same time delivering customer service. Hitting,
well, we have two questions related to that, and they're related to each other. One was, how do you use data when you've got a small N size or a small sample size? And related to what you just said, how many actual surveys do you get on each physician, say, in a quarter?
Oh, that's another great question. That is my biggest challenge when I'm going to providers and I'm saying, hey, your score's a little soft, whatever. The very first thing they hit me with is the N number. That's the most common argument. And I accept that. It is a weakness. I mean, you cannot argue with that, certainly from a scientific standpoint. But what we look at, and I never beat up anybody over a quarter or even 2 quarters of performance, but when we look at over a year of data, I mean, I think that the correlates become pretty reliable. And so that's basically what we look at is from the N standpoint or the gross scores, we look at the long term. Now the comments, the specific comments, man, you can't argue with those. You got a patient saying, hey, provider A came in, they were rude, they treated my family rude or whatever, or conversely, it may be great. It may be a positive comment. We spend a lot of time on those positive comments too.
Good. And we have time for one more. Paul, if you could quickly, the other question, we had 2 different people ask a similar question. Considering the staffing shortages, particularly when you deal with physicians and mid-levels, what is the candidate reaction to some of the selection tools that you're talking about?
Yeah, that's another good question. So this is actually one area of research that we do quite a bit of when we administer our assessments, just to look at what are the candidate reactions to the tool. So we actually survey them after they go through the assessment. And the other thing we look at is something we call abandonment rates. So the good thing is when we look at our survey data is we get wildly positive results that folks are very happy and pleased with their experience with the assessment, and they generally think favorably of the hospitals that are using them because they think they're using them to select better folks. And then on the abandonment rates, we see less than 1% of folks who start an assessment actually don't complete it. So we're getting like 99.9% of folks going through, which is another great stat. And something that when I work with my clients, I know especially in allied health and some of the hard to fill areas, they're very concerned. They don't want to lose the candidate, and so we have some good data to suggest that we're really not losing candidates by using sophisticated methods. We're just getting better measurement.
And Kathy, it looks like we're out of time, but I've got about a dozen other really good questions from the attendees. So I'd like to let everyone know that we will get those questions to Paul and Dr. Hold and try and get responses directly to you. But thanks for having us, Kathy. We tried to cover a lot in a short amount of time, but hopefully it was helpful for people.
Okay, well, thank you, Bryan, Paul, and Dr. Hold. Your presentation was extremely informative and enjoyable. I'd like to thank again our attendees for participating today, and we look forward to having you join us for future webinars. This will conclude today's program, and have a wonderful afternoon.